Hello, everyone. Welcome back to Discussing Disparities. My name is Pranav Kancharla, co-founder of Health Needs RX. If you're new to our organization, we are an organization with a mission to mitigate health disparities through educational video content and information guides on essential topics like chronic diseases, mental health, respiratory illness, health literacy, and more to help people optimize their health. We also strive to spur discussion on health disparities and the state of them today through our blog MedQuity and this very podcast. On this episode of Discussing Disparities, I'm joined by Dr. Adams, Professor of Medicine, Community and Family Medicine and Epidemiology, Associate Dean for Global Health, and the Director for Global Health Equity at Dartmouth College, who will talk more about tuberculosis health disparities. Thank you so much for joining me today.
Very pleased to be with you today.
What sparked your interest in this field of research?
So it's a great question, and I can tell you that I entered medical school, now more than 30 years ago, with a great desire to work with underserved populations. That was my main motivation for wanting to go to medical school in the first place. And then during my training, both as a medical student and as a resident in internal medicine, I did electives with sort of testing out places where I might want to work, and I did some work with healthcare for the homeless in Boston. I did electives with the Indian Health Service at some of their care sites on the Navajo Reservation in New Mexico and Arizona. But then it was in the last year of my residency that I did my first global health elective, and that's when I really fell in love with the work of global health. It ended up being an elective working in Albania, and so my first job out of residency was to return to that region. I had Albanian ancestry, and that's what really drew me to that part of the world. And that project right out of residency happened to be with a group called Doctors of the World, and it happened to be a TB program. So right away, I was sort of thrust into the world of tuberculosis care and prevention. And right away, I appreciated that TB is often considered a disease of poverty. And that's because it affects people who are living in overcrowded, living conditions, households where poor nutrition is common, and then other vulnerable populations like those living with HIV. Now, of course, tuberculosis can affect and does affect people of every and all socioeconomic statuses. So it's important, of course, and I want to be careful not to profile TB patients or those who have been diagnosed with TB. But it's very clear that there's a very severe stigma associated with tuberculosis, and I was always drawn to work with diseases that have accompanying complicated, oftentimes, social factors associated with them. So some people have said, well, is tuberculosis a medical disease with social consequences? Or in fact, maybe it's almost more of a social disease with medical consequences, because that's how important the social overlay and social factors, and really what we would now might call social determinants of health, are in terms of their interface with tuberculosis. But the other reason too that I think it's why tuberculosis is and remains such an important issue, and why I've decided to devote my professional career to contributing to the elimination of tuberculosis, is that tuberculosis is now the leading infectious disease cause of death. Okay, we have 10 million cases that were estimated to have occurred in the last year, and about 1.4 million deaths from tuberculosis, and that's quite a bit more than the roughly 700,000 estimated to have occurred in the same year from HIV. So just keeping in mind that tuberculosis doesn't always get the airtime and sort of the quote unquote publicity that other diseases get, it really is an important global issue and global challenge. And so that also is sort of supports and fuels my decision to devote my career to tuberculosis.
Oh, that's so inspiring. What exactly is tuberculosis, and how prevalent is it in the United States?
Yeah, well, I'm great to be able to explain this, because it's important to understand that tuberculosis is an infectious disease caused by a bacteria, Mycobacterium tuberculosis is its name. And it's important to understand that it is treatable, and in most cases, the vast majority of cases, curable. So with a disease that is curable, we have had the drugs for decades to be able to cure it, why does it still persist? And why is it now the leading infectious disease cause of mortality? So it's important to understand the certain features about the disease that make it still a tremendous global health challenge even today. So tuberculosis can infect any organ, just about any organ of the body, but about 80% of the time it affects the lungs and causing sort of a pneumonia-like presentation, with predominant symptoms being coughing, including coughing up blood, fevers, night sweats, loss of appetite, weight loss, chest pains. And it is actually through this cough predominantly, which is how TB is transmitted. It is airborne transmission. I know through the COVID pandemic, we're learning a lot about, respiratory droplets and aerosolized transmission. So that is how TB is spread. So if someone coughs in a room and there's no air exchange, those TB bacteria can survive in the airspace. Now we know for up to 8 hours. So again, easily spread if there is close contact, particularly among households where there's shared airspace, and why you can imagine that overcrowded living conditions can contribute to its spread. TB also has this insidious onset. So it's not immediate. It's not like you feel well today and then tomorrow you wake up and you've got this, cough and fever and headache and feel lousy and feel, acutely ill. That's not tuberculosis. That's the flu or some other respiratory infection generally. Tuberculosis has this sort of waxing and waning features to its presentation. So you have a cough, you have some fevers, low-grade fevers maybe, and then they come and they go. You start to feel like you're getting better. And human nature being what it is we don't want to rush to the doctors with the first symptom. We say, well, maybe this is going to go away on its own. What that means, though, is that people often have tuberculosis, are coughing, and again, with this sort of waxing and waning presentation, for months before they seek medical care. Average delay to seeking care is about 3 months from the onset of symptoms. So part of that is around access to care, but part of it, again, is just human nature waiting to see if this is going to get better, because it might appear like it's getting better, then it'll get worse. So that feature contributes to the spread of tuberculosis. Again, so it mostly affects the lungs. It can affect other organs. The other organs most commonly are the lymph nodes, your bones, especially the spine, or the lining of the brain. It can cause a TB meningitis, or it can be disseminated throughout the body and detectable in the bloodstream even. So it has many different presentations, but it is most commonly this pneumonia-like illness. So just a couple features too about about tuberculosis that have made it hard to identify and eradicate. And I think these are important features to understand. So the bacteria that cause tuberculosis are slow growing. So they take a long time to grow in culture in the lab. So that can be from 2 to 8 weeks of time. So that's not very convenient if you're a clinician and you want to take a specimen from a patient, and what are you going to say in the doctor's office? Well, come back in 2 to 8 weeks and I'll tell you what your diagnosis is. So again, the culture is the definitive diagnostic test that we've had, but the fact that the bacteria grows so slowly has really hampered our ability to be able to offer a diagnosis in a timely fashion. The good news is that there are, now we've had for about 8 or 10 years, we've had a newer diagnostic test that can give the result in a matter of an hour or two. You can give a sputum sample, run it through this nucleic acid amplification test, and get a result in about 90 minutes. So that has transformed our ability to diagnose patients, and that's something that is fortunately has been rolled out worldwide. That platform, that diagnostic platform, is widely available. So that has allowed us to make some great improvements in diagnosing TB most recently. So the other characteristic that I want to share is that treatment takes a long time. I always say if TB were a disease that you could treat with a 7 or 10 day course of antibiotics, we'd be done. I don't think we'd be seeing TB today if that were the case. But typically, to treat the TB bacteria when it is sensitive to the standard drug regimen that we have, can take 6 months. So anybody who's had to take an antibiotics for 7, 10, 14 days knows that it can be really hard to take those last doses. You're starting to feel better. You may not actually be like, oh, do I really still need to finish this course of antibiotics? And imagine if that's the case where you're taking a set of antibiotics for 6 months. People start to feel better after a few weeks, certainly with a few months into treatment. But if they don't finish that course, they are likely to relapse. So it is really important to finish that course, but it's just been hard when it is so lengthy. That's if you have drug-sensitive TB. If you have drug-resistant TB, we're talking about treatments that can last 18 to 24 months. So it's a real commitment. It takes real sort of stamina and perseverance to be able to get people through their drug regimens. They're taking multiple drugs at the time. Some of them can have serious side effects. Some of them just makes people feel unwell to be taking 9, 10, 12 tablets at a time. So we have been working really hard to simplify the TB regimen. And now there are advances and studies that are the results of which are just being presented literally as we speak. And in some cases, some regimens, shorter regimens being rolled out. So now we're looking at maybe we can shorten the course of treatment for drug-sensitive TB to 4 months and make it as short as 9 months for drug-resistant TB. Great breakthroughs, again, happening in the last year or so. And then the last but important feature I want to mention about TB is that TB has these two forms. It can exist in that active disease state where you're coughing, have fevers, sweats, chest pains, etc., or it can exist in this latent or dormant or quiet form. So what happens is someone gets infected with TB, right? If I breathe in the TB bacteria into my lungs, and the TB bacteria go into and set up residence in my lungs. One of two things can happen, really. I'll simplify it a little bit. There's other options too, but really what happens is either I go on right away to develop active TB disease, it makes me sick immediately, or my immune system kind of walls it off and is able to keep that infection under control, and I have this latent form of infection. Now, it's really important to understand how common this latent form of infection is. This latent TB infection, or LTBI as we call it for short, about 25% of the world's population has LTBI, so in this dormant or silent form, which is also a non-contagious form too. As long as the bacteria are walled off, you can't spread it to others. The issue now is that we know that we have this large sort of reservoir of people with TB in this latent form. Only about 10% of people who have healthy immune systems will go on at some point to progress to developing the active disease. That can happen a year later, that can happen 5 years later, that can happen decades later. We don't know when, and we don't know exactly who is going to go on to develop TB disease. So our approach is to treat everybody, and certainly those at highest risk for progressing from this latent, silent, non-contagious form of TB to TB disease. So treatment for latent TB infection is also available. In the US, our regimen had been 9 months of an antibiotic. Fortunately, in this case, it's only one drug that you have to take. When you're treating TB disease, it's 2 to 4 drugs at different times during the regimen. So 1 pill a day for 9 months. Again, when you feel well, you have no symptoms, right? It's in that dormant stage. Really hard for people to finish that regimen. So again, good news. In the last couple of years, we now have shorter regimens. Still not as short as we would like. It's still not that 7 to 10 day antibiotic treatment. Now our regimens for treating latent TB infection are between 3 to 4 months in duration. So again, it keeps adherence being a challenge, but we are making progress in this area.
Thank you so much for such a thorough response on TB. I just wanted to ask, regarding latent TB, what are sort of the risks of having that infection, beyond just progressing to the active form? Are there any inherent risks in just having latent TB? Interestingly,
No, it's really The risk is really just that you could go on to progress to developing active TB. We don't think that there's any other sort of serious consequences or sequelae. In fact, we know, and again, keeping in mind that only 10% will go on to progress, that means 90% will not, and 90% of those who have latent TB infection will go on, live normal, healthy lives, and die of something else with that latent TB still in their lungs, so without it causing any problem.
Oh, that's really interesting. I also wanted to ask, like, how does TB affect like youth and adults differently? Like, what are some differences and similarities?
Yeah. So this is a really important question. And yes, I should have warned you when I start talking about TB, I can talk quite a bit about it, but I'm trying to give you hopefully background that will be really helpful to understand why this is still such an issue. And you raise a good point now in terms of thinking about some of the disparities, because I think it's fair to say that TB in children has been a previously neglected area of TB care and prevention. And it's an area where I have, in recent years, made a focus of my work in TB care and prevention, because we know that unless we are able to, if we don't have devoted advocacy and efforts to address TB in children, that they could continue to be neglected and suffer significant morbidity and mortality. So the reason why children have been lower on the priority scheme for tuberculosis programs is mainly because children are generally not infectious. So we call them sometimes the innocent bystanders of a TB outbreak or in a household or community. So that's because children generally aren't coughing with the same force as adults. So they generally aren't efficient transmitters of the disease. So in all settings, where there's a lot of active transmission, a lot of active disease going about, and halting transmission is the priority from a public health standpoint, less attention has been paid to identifying and treating children. Now, it is important, and I will stress this, it is important to treat children, identify them and treat them, because young children, especially infants and really those under age 5, are more likely to die from their TB disease because they tend to get the disseminated forms of TB in the bloodstream or TB meningitis, and those are the life-threatening forms. So again, from a public health point of view, they're not transmitting it, they're less of a concern, but from an individual patient point of view, of course, it's important to diagnose and treat children. And fortunately, there's been great advocacy work done by the Union Against TB and Lung Diseases, again, by the Stop TB program and other partners. Great advocacy efforts to put childhood TB on the global agenda. And many efforts now exist to try to identify and treat children. Again, it's been complicated because for many years, we had just the roughest estimates of how many children even had TB in the world. We're getting much better at our modeling and being able to record and track TB in children now. There's been a big push for having better data, because without the data, we don't know the magnitude of the problem. So we're getting better data. It's been difficult because children are generally diagnosed purely by clinical presentation, because really all of our diagnostic technologies, even the newer one that I was mentioning that we've been able to roll out over the last several years, they all require a sputum specimen. So how do you tell a 4-year-old or a 1-year-old, or let alone a 6-month-old, to go cough into and spit up into a specimen cup? So you can't do that. So it's been difficult to get those specimens. We've tried to, because children swallow their sputum, we've have a technique where we insert a tube down their throat and pull out the contents of their stomach early in the morning to try to get this sputum specimen. I'm very pleased to say that I'm part of an effort now looking at newer approaches for diagnosing TB in children, and including using stool as a specimen with that newer technology platform I was mentioning. So that, and I'm involved in helping to develop some interim guidance on this approach. So again, some great progress being made, but really for a long time, children with TB, again, they were just sort of the innocent bystanders and not the focus of TB control or TB care and prevention efforts. So glad to see that disparity gap being closed.
That's amazing, especially closing like that age gap. That's awesome. I also noticed that you've done a lot of work in like Tanzania. So what sort of like global differences are there in access to preventative treatment like isoniazid for preventative care?
Yeah, another great question. So we have, I've been involved in work with our partner institution, Muhimbili University, and through what we call our DarDar program. So it's Dartmouth and Dar es Salaam. Of course, and it's actually our Tanzanian partners who helped us come up with that name, because they said we really like DarDar because it mimics the Kiswahili word dada, which means sister, and we all agreed that sort of captures the spirit of our collaboration. So through the DarDar program, through our partnership with Muhimbili University, I've been able to do some work in helping to implement and roll out preventive therapy to treat. We used to call it preventive therapy. It still is referred to that, but really what we're talking about is treatment for latent TB infection. People think of it as preventive therapy because it prevents the progression of latent TB to active TB form, but it can be misleading because people think, well, I don't have it. I'm actually just preventing it from myself from getting it. But actually, you have the infection. What you're preventing is the progression of the latent infection to disease. So I think that's just an important distinction, because sometimes people say, well, preventive treatments are ancillary or a luxury. And really, for a long time, treatment for latent TB infection has been considered a luxury in low and middle income countries like Tanzania. And again, that's because the focus has been on identifying and trying to cure those who have active TB disease, since they're the ones who are going to be able to spread it in the community. But fortunately, in the last several years, greater attention has been paid to treating latent TB infection in low and middle income countries. Again, recognizing that those are the future cases of TB in the country. Again, having to prioritize, the efforts have really been on treating those, identifying and treating those at greatest risk. And so those two cohorts are people living with HIV and childhood contacts. So that's generally children in a household of someone who is diagnosed, of an adult who is diagnosed with infectious TB. So some of my work on helping to roll out what we call TPT, TB preventive therapies now, has focused on introducing and rolling out latent TB treatment to these two high-risk groups, again, in an effort to try to treat them before they develop active TB disease.
So that definitely makes more sense. Like, why you choose to like work with the HIV clinic to implement IPT care? So is there anything like you learned specifically from that experience?
Yeah, we certainly learned a lot. Just to give the background too, in most countries, I think even in our own, these different disease control or disease elimination programs exist in silos, so that there's for example, in Tanzania, there's the National TB and Leprosy Program, and then there's the National HIV/AIDS Control Program. So two different programs running in parallel, without really recognizing that many patients are crossovers and need to be receiving care from both programs. So one of the things we did, and this is both in our work in Eswatini, the country formerly known as Swaziland, and also in Tanzania, was to try to integrate care so that TB preventive therapy could become part of someone living with HIV, become part of their regular HIV care, and actually include the medicine. In this case, it was isoniazid, include that medicine in with their antiretroviral, their HIV medicine refills. And this is important because integrated care is clearly more patient or person-centered. It's more a person-centered approach. And think about it. If you had to go get care for your HIV disease, you'd have to go to the HIV clinic. queue in line there, wait to to be seen, and then you'd have to go to the TB clinic, start all over again in another queue, wait to be seen, and it was not very practical and not very, again, patient or person-centered. So by integrating care, we simplified the care for the patients, made it more streamlined and easier for them to get care. The other thing that we did was that was important for our research was that we gave patients a choice of receiving their care and their medication refills either at the clinic where they came in to see the providers, or through community-based or home-based care. And this was fascinating because as soon as we said to patients, well, we're also offering you a choice. Where would you like to get your care? They many times patients are not given choices in their medical care delivery. And so we certainly saw this in our with our patients in both Tanzania and Eswatini, that I think it provided a different kind of engagement of patients with their care. So it wasn't a clinician telling them, this is what you're going to do. You're going to take these medicines and you're going to come here once a month or once every 2 months or whatever to get these medicines. All of a sudden, they were now engaged in a partnership around their care. I'm very pleased to be at Dartmouth, which is one of the sites where shared decision making was actually, the whole concept was actually born. So being able to engage patients in their care, we think really helped with their adherence to it. They were active participants. That provided them some agency. And it was fascinating to see how patients and why patients chose one option over the other. We had speculated how this might roll out, but what we saw actually was that people made choices for very clear reasons, and they were not necessarily what we expected. So some patients chose to come to the clinic. And why did they do that? We thought it would be so much more convenient for people to get care at home and to not have travel. And they're like, no. If I have healthcare workers coming to my home, I might, my confidentiality might be breached. I'd rather come to the clinic because I have better confidentiality in doing so. Plus, I have my routine, like every time, every month or every other month when I need to come in, I swing by on my way before going to work, or I come here as part of other, work I need to do in this part of town. They had their routine, and they said, I want to keep that routine. Whereas people chose home-based care in rural areas where the houses were spread a little bit further apart. They felt like they could have a little bit more privacy, and where you might imagine transportation would be more challenging. So it was great to be able to go back and ask patients why they chose one option over the other. But I think it was most of them chose to come to the clinic, which the health system would have assigned them to if just for ease of the health system. But I think it was just the fact that they chose it, brought about, again, a sense of self-efficacy and agency. So we were very pleased, and we had very high treatment completion rates, approaching 90%, which in the literature previously it had been anywhere from 40 to 60% treatment completion rates. So we were very pleased with the results that we got from this work.
That's amazing that you were able to improve patient adherence that much. That's really cool. So why don't we get the BCG vaccine in the United States, and where is this vaccine administered?
Yeah. So the BCG vaccine, it's one of our oldest vaccines. It's also one of the most widely used vaccines in the world. It's given essentially in every country outside of the US, Canada, and I think most of Western Europe. Now, it's a vaccine that's given at birth, and it is very effective in protecting children. And you think for about the first 2 years of life. There may be some protection that goes on past that, but it's really those first 2 years of life where we think it provides up to about 80% protection. And that's important because, as I mentioned, young children are that when they get TB, they're more likely to get the very serious, life-threatening forms of TB, and therefore suffer the greatest morbidity and mortality. So I always say this vaccine is important for saving the lives of children, but because these children are not likely to be contagious if they do develop TB, we don't consider it, and the public health system doesn't consider it a disease control strategy, as many of our other vaccines are. So, that I think is important. Again, it's important for child health reasons, but we don't think it actually contributes much to controlling the global rates of TB. And it's not given in the U.S. and the other countries I mentioned, largely because, fortunately, our rates of TB are so low. So in that case, sort of its benefit does not really outweigh the cost of including it in our immunization program.
Yeah, that makes more sense. Thank you so much for elaborating on that. So what disparities exist in regards to access for education for TB?
Yeah, so I've had the privilege of being involved in programs to help train healthcare workers at all levels for TB, and particularly for pediatric TB. As I mentioned, we've really been trying to put some emphasis into making sure that our healthcare workers are comfortable and understand the approaches to take with children with TB. But also for the general population, it's really important, of course, for us to have, family members, for all adults to really understand what are the signs and symptoms that would be consistent with TB, so they know when to seek care. So community education programs have really been a very important part of TB care and prevention efforts. And again, I think they're most effective when they're done at the grassroots level, when they involve local leadership, sort of local trusted individuals to help provide that community education. And there's a lot of different ways in which it can be done through, clever, catchy, campaigns, whether that's through, billboards or radio announcements or word of mouth, or through women's groups. If as women are often the primary givers for children. So just trying to sort of help everyone understand, if you have a cough that doesn't go away, we use the rough time frame of 2 to 3 weeks. A cough that persists for 2 weeks or more, and with the other symptoms that I mentioned, of fevers, particularly sweats and loss of appetite, then it's time to go seek care from a clinician. But I've also been involved then on the other side, as I said, with the healthcare worker training program, since unless you're seeing TB regularly, clinicians don't necessarily keep TB in their mind as a potential diagnosis. And the benefit of having TB cases decrease worldwide, as we have seen over the last few decades, is that as clinicians see fewer cases of TB in their offices, in their health facilities, it sort of starts to recede or fade from their thinking, and it may not be something that's on the top of their list for diagnosing a child or an adult with TB. And the symptoms, as I mentioned, are somewhat nonspecific. I mean, they could, it could be another bacterial pneumonia, it could be a viral pneumonia, either an upper or a lower respiratory infection caused by any other pathogen. So we have sort of our slogan or our motto for our clinicians, and we have posters, and the CDC in the US has been great about producing these posters that say, think TB. So keep TB in your mind, when they present with these, what we call sort of non-specific symptoms, to keep in mind, though, that TB should be on what we call our differential diagnosis. So it should be on the diagnostic list. And then I've also done work to help just ensure that appropriate protocols are being followed with children with TB, since, as I mentioned, diagnosis in that is in that age group is more challenging.
Yeah, and going back to diagnostic methods, I know you were mentioning the faster diagnostic methods. What are the disparities in access to testing for TB, the newer blood diagnostic tests that you're talking about, like an IGRA?
Yeah, so the newest diagnostic for diagnosing TB disease is called the Gene Expert MTB RIF. We call it Expert or Gene Expert for short. And that requires a sputum specimen. And I can tell you one of my favorite moments in my TB professional life was when I was based as a clinical faculty member for 6 months in Rwanda, and I was in Kigali, and I had heard, this was in 2012, and I heard that the new gene expert machine was arriving at the lab at the hospital lab. So I immediately, as soon as I was free, I went over to the lab, and I was so excited to see this new machine. They were just really still sort of unpacking it and setting it up and getting ready to start testing it and implementing its use. And I was running around taking pictures of this new gene expert. So most people in Rwanda are running around taking pictures of the gorillas and the landscape. And so I'm running around taking pictures of the gene expert machine as it's being unpacked and set up. So that was very exciting because at that time in 2012, that gene expert machine arrived in Rwanda while we did not have one at our medical center at Dartmouth. And I thought that's just right, because we don't have that many TB cases. Certainly we don't have that many TB cases in the US compared to Rwanda. We have very few TB cases in New Hampshire. So I thought that's the right priority, that Rwanda should be getting this machine first. So that was, again, it's been 8 years since, the rollout has really started of these machines. So that those now are, those machines are available in most reference labs in low and middle income countries. So that's great news. The problem is that there still needs to be better access to them because they tend to be centered in, placed in urban centers. And so it can still be hard if you're in a peri-urban or rural area to be able to have access to that diagnostic test. And that diagnostic test, it's relatively, simple to operate, but it does require electricity. I think they're still processing specimens under a hood, so it does require a laboratory setup. It's not what we call a point of care test. And a point of care test would be like a finger prick test for malaria, for HIV, or a swab from inside the inside of your mouth that could be processed right there in an outpatient clinic. This requires transport of specimens to a laboratory, and often it's a higher level laboratory where that can be processed. Now, the other test that you mentioned is the IGRA, the interferon gamma release assays. Those are used to diagnose latent TB infection only. They may or may not be positive in TB disease, only because in TB disease, your immune system can be overwhelmed and actually can render that test result to be negative, even when you have active TB disease. So those IGRAs, these newer blood tests, are really used just for diagnosing latent TB infection. The other test is the PPD skin test, or tuberculin skin test. That's complicated because that requires refrigeration, so you have to be able to maintain a cold chain for using that. There's challenges for using both of those in low and middle income countries. The IGRAs are becoming available in, there are some efforts to roll them out in low and middle income countries, but they're still quite costly. So I think we will see changes in the coming years. But right now, the IGRAs are pretty much only available in high income countries. I will say, as long as TB is quite prevalent in countries like Tanzania, Eswatini, South Africa, other places where I work, they don't even test people for latent TB infection. If you're a person living with HIV or childhood contact, studies have shown it's more efficient, and the risks and the benefits are so likely, and the risks are so low. It's better to just treat people without even having to go through the confirmation that someone has TB in this latent form, because it's so common. You can make the assumption that they have TB in this latent form. So again, lots of different ways in which we, approach both TB treatment and or particularly latent TB diagnosis based on prioritizing for different settings.
Yeah, absolutely. In regards to transportation and access to care, what sort of disparities exist in regards to coordination of care delivery?
Yeah. So I will say, I think the the silo model that I was mentioning about care exists. That's a universal challenge, I think. Trying to find someone who can make sure that they can actually treat both your TB and your HIV concomitantly without having to send you to different specialists. That can be an issue in the US. Certainly, my infectious disease colleagues are treating both HIV and TB at the same time. But there are still challenges to finding sometimes the right expertise and people or clinicians with the right expertise to be able to treat both diseases, and again, really provide that patient or person-centered care. It's challenging because people develop their areas, their niches, their areas of expertise. But I think we're all recognizing that integrated care, which we've been talking about for a long time, for a decade or more, as being the model that we all want to pursue. It's just hard when the health systems, the infrastructure of the health system, the organizational structures of health systems haven't really been able to support that, I think, in the way that many of us would like to see. Again, a bit of a universal challenge, but certainly a challenge that I face in quite a bit in my work in places like Tanzania.
Absolutely. And going off another disparity and challenge, the coronavirus pandemic. So how exactly has COVID affected tuberculosis disparities?
Yeah. So another great question. We know that the COVID-19 pandemic has disrupted almost every sector, every, I think country, so many communities have felt its impact, and it's been just such a global tragedy in so many so many settings. What we know it has also done in almost every setting is had people delay care for other illnesses. Right? We've talked in the U.S. We're talking about all the people with myocardial infarction, heart attacks, strokes, who are staying home and maybe not seeking care in the way that they would normally, in the way that they should be. And that has been certainly raised as an issue in the U.S. I can tell you when it comes to TB control that there are some global estimates that unless additional measures are put in place, the kinds of lockdowns and fears that have accompanied individuals seeking care, I think unless something is really able to reverse those challenges, that we think that there will be a very slow return to services for TB care, and the estimate is that it could lead to up to an additional 6 million cases of TB over the next 5 years, and an additional 1.4 million TB deaths. So keep in mind that each year, for the last few years, it's estimated there's been about 10 million cases of TB, as I said. And so this is an additional 6 million cases over the next 5 years that we're looking at, and an additional 1.4 million deaths. And that, again, is on top of the 1.4 million deaths that we're already seeing. So again, I think the disruption of care services is significant. I will also say that, and so the estimate is this will set the global TB community and its efforts back by about 5 to 8 years in our global fight to end TB. I will also say that many infectious disease TB clinicians have been pulled into the coronavirus response efforts, myself included. I have a leadership role at Dartmouth on the co-chairing our COVID-19 response task force at my institution. Many of my infectious disease colleagues at Dartmouth Hitchcock Medical Center are also pulled into either because they have a role at the state health department, or they're involved in the medical centers and our health systems response. So many of my colleagues I know have been pulled into COVID response. So we will really, when we are on the other side of this, have a much better picture of understanding the full impact that this, addressing this pandemic has had on patients with tuberculosis. And it's just, in my mind, just another, sort of tragic fallout from the current pandemic, and another way in which disparities, again, have been exacerbated during this pandemic.
Yeah, absolutely. I know we all want like the pandemic to end soon, and I just really hope that, all these disparities can also be addressed. But thank you so much again. But also, would it be possible for you to talk a little bit more about how the Center for Global Health Equity works to combat like the tuberculosis disparities, talking about like the DarDar and Rwandan Human Resources for Health program?
Sure, I'm happy to. Let me just point out a couple features that I think are unique or certainly worthy of mention regarding our approach to the global health work and the health equity work that we do. Our Center for Global Health Equity was established first as a Center for Health Equity at the medical school, working in collaboration with the college's Global Health Initiative. And now we're really joining forces to have the Center for Global Health Equity as one overarching center for the entire institution, Dartmouth campus. And one thing that we recognize is that there's more similarities than there are differences to combating health disparities wherever they may lie. So we have joined to have both global and domestic health equity programs. So we're working locally. Some of my colleagues are involved in looking at disparities that exist for our rural populations during the COVID pandemic. But we've also been involved in other domestic health equity activities, such as working to provide care to migrant farm workers who come to our New England states, and working with our free clinic for medically indigent individuals. Globally, we have a distinct number of partnerships. And I will say, really one of our other, in addition to sort of merging global and local or domestic health equity issues, is building a model of equitable partnership. That has been critical to our work. And what I mean by the equitable partnership model is really where our partners' priorities drive our agenda. They set the priorities for the work that we're going to do. We figure out how we can best align to support meeting their priorities. But it's very much partner-driven. And that has been critical for our work on our capacity building training grants. That's been critical for our disease, care programs and interventions, our research activities. So we really try to work in equitable partnership as best we can, recognizing that we are having to cross a large chasm of historical legacies, of inequity and a power dynamic and a financial imbalance. So we work really hard to ensure that our partnerships are as equitable as possible. The second feature I will mention is that we place a high priority on having reciprocity to our programs. So many, global health programs are about sending, the institution's students out into the world to do work in various countries, and we certainly do send our students to Rwanda to work in collaborations in Tanzania. We have partnerships elsewhere in Peru, in Kosovo, and partners working in Vietnam. However, we also feel like it's important then to be able to receive. So if we're going to send out our students, we have to have reciprocity so that we are prepared to receive and support receiving students from our partnership institutions. So we have a number of bilateral medical student exchanges. They're not exactly one-for-one, but they're getting pretty close. So similarly with faculty too, if our faculty are traveling to do work in one of our overseas sites, we also try to find ways to bring our partners to Dartmouth for either training opportunities, for broader sharing of our institution and the kind of services that we can offer and bring to the partnership. But that reciprocity piece is so critical. It really cannot be a one-way street. That is in my mind, the death knell for a partnership. So reciprocity is critical. And then the last thing I'll mention is that we really work on building what I refer to as sort of durable partnerships and professional relationships. So rather than being in many countries, kind of with lots of pins on the map or dots on the map, we're really about building deeper relationships with a smaller number of country partners, because I think I keep on saying we're in it for the long haul. And so in order to do that and to build the kind of professional relationships, build the trust, work together over years, it is a long-term commitment. So that's I guess another feature I would say, but that's I think critical to our work. Our DarDar partnership has been in place now for almost 20 years. So that gives you an idea of the kind of commitment we make.
That's amazing what you've been doing that for 20 years. I love the emphasis on sustainability and partnership drive. Like, that's amazing and inspiring. So and going back to the TB discussion, what sort of policies would mitigate TB risk in medically underserved communities?
Yeah, so I think working with underserved communities, one of the key features is understanding the importance of good communication and trust. I think we're hearing about this. I'm certainly very attuned to it, so I see it in the things I'm reading about the COVID pandemic response. That, and I know from my own experience in working on the front lines of the response for our institution, that having good, transparent, clear communication is absolutely critical. Okay, so that could be in the form of communication to communities, to individuals, to understand what are signs and symptoms of TB, understand what's going to happen once they are diagnosed with TB. Being able to communicate in communities that TB can strike anyone, and that and trying to do some of the anti-stigma work to make TB a little bit more normative, so that it's not such a stigmatized disease, and that this is not it's not associated with poor hygiene or anything that a person has done themselves. This is not something that there should be no shaming and blaming, and we're talking about that too with COVID too. No shaming and blaming when it comes to infectious diseases. So the other piece too is, in addition to sort of good communication among communities and healthcare worker colleagues as well, is having really trusted allies and outreach workers. I think that's been really critical too, because it's, if we know that certain groups are at higher risk for contracting a particular disease, you need to have someone from that community who is going to be a trusted individual to help build the bridge, be the liaison to working with the public health community and the public health system, and that's been so important. There's been a lot of great examples around that that I think have gotten some good publicity around, that's being done around COVID, and having leadership at all levels sort of set the example and provide information, help people make their own decisions, but really encouraging trust in the healthcare system. There's again another many years of complicated legacies that make it very understandable why people may not and certain groups in particular may not trust the healthcare system and the public health system, right? And thankfully, again, more light being paid to issues around systemic racism and structural violence. And so understanding those histories and figuring out how do we acknowledge them, and then how do we still work to reach out to those communities and provide them the information and the best services that we can. That's all been a critical part to our work.
Absolutely. And in considering like those structural differences and communication, how could these findings assist healthcare providers in delivering better care for patients with like active TB and latent TB infection?
Yeah. So I guess my message is I keep coming back to the idea of working in partnership, and in this case, working in partnership with patients to try to practice some shared decision making. The other piece that I didn't mention that we did in our studies with rolling out TB preventive therapies was we did some training in motivational interviewing for our clinicians. And again, motivational interviewing is just a technique that's really a part of shared decision making, because what you do is it engages the clinician in a discussion with their patient to find out what matters most to them. And that is, again, if I'm talking about taking a medicine and for a disease that is not causing you any symptoms right now, and you've got a million other things going on in your life and in your world, and this is not a priority, you're probably not going to take that medicine. So being able to really find ways to actively engage with our patients, giving them, again, that greater self-efficacy, that greater agency, I think is one of the things that we can do to help our patients really be successful with their care and treatment for both TB disease and latent TB infection.
Yep, absolutely. Context matters so much, and thank you so much for elaborating on that. Well, and that was actually our last question as well. Thank you so much for joining us on this podcast, Dr. Adams. It was an honor to have you, and it was really insightful to learn so much about tuberculosis healthcare disparities.
Yeah, well, my pleasure. And always, as I said, very eager to talk about this, what I think is important work in tuberculosis care and prevention. And we know that so many people have been focused on the COVID pandemic. But it's really important, I think. We're seeing a light at the end of the tunnel for COVID, so we know we have to be, we can't lose sight of what challenges we have to address around tuberculosis and other diseases when we're on the other side of this.